What's going on, everybody? Welcome to another episode of the Core Consult RX podcast. Cole and I are back at it with another accredited episode for continuing education.
Yes, just us though.
Just us.
No AJ today.
Unfortunately, AJ had family obligations.
More important
so we'll
things.
let it slide. I
Maybe.
guess our executive producer. We might demote him. We'll see.
Just he's producer now.
Just producer, no executive.
Or de-executive.
He's been de-executivized. That's
Nice.
a new word. I like that. So, Cole, what are we chatting about today?
Yeah, so we've talked about this a little bit in the past, but we're going to take a little bit of a different swing on it today. Crohn's disease. So we've talked about IBD, which is Crohn's and ulcerative colitis, but we're going to focus on Crohn's today. There's a new guideline, reasonably new, in the last year at least, that will hit a couple points on that. And then we're going to kind of talk a little bit about colon cancer screening, increased risk of colon cancer with Crohn's disease, and some updates to that over the last few years too. So lots of good stuff.
Yep. So you mentioned IBD, inflammatory bowel disease, can be both ulcerative colitis and Crohn's disease. But when we're kind of thinking about some of the differences to kind of distinguish, those, we typically think of ulcerative colitis as being more confined to the rectum and colon specifically, whereas Crohn's disease can kind of happen along the entire GI tract. So transmural inflammation, and it makes it potentially a little bit harder to treat because it takes away some of our older treatment options and things like that, which we'll discuss. But I think we did ulcerative colitis last year, so if you are interested in more in-depth detail about that, check that episode out. But since we're going to have some new guidelines and all that, we'll focus on Crohn's disease specifically.
Yes, we will focus on Crohn's, but there's a lot of overlap with them as far as the etiology and even a little bit of the pathophysiology goes. And it's hard to talk about the treatments without at least touching on a couple things related to UC. So you'll hear us mention a couple things, but the focus is on Crohn's. For both of them, it's kind of there's complex reasons why it happens, and various reasons why it happens. So it can be immunologic, infectious, there's genetic components. With immunology, it's frequently associated with being autoimmune, an inappropriate T-cell response to the intestinal flora, overproduction of tumor necrosis factor, overexpression of interferons, so inflammatory mediators that we're familiar with. With infection, it can be alterations to the normal flora, so bacterial overgrowth, or bacteria-produced toxins, that sort of thing. And there's definitely high genetic associations. So a lot of twin concordance rates, several genetic biomarkers that have been identified, so definitely can be genetic as well.
And even environmental factors. So certain things like our Western diet, it puts patients more at risk for developing IBD in general. And so thinking about things like, diets that are low in fiber, high in simple sugars, additives, refined foods, things like that, all potentially can add to it's the overall adding of the inflammation properties. Nicotine, for example, and this is where one first things I think of as far as the differences between some of the ways that social factors can affect inflammatory bowel disease, whether it's ulcerative colitis or Crohn's, because nicotine actually worsens Crohn's disease, which we always think of cigarettes as being associated with negative outcomes, but it is actually protective in ulcerative colitis. That's one big difference. Not that we're suggesting to tell your ulcerative colitis patients to go start smoking, but it does potentially run the risk of them losing kind of control of their symptoms or taking them out of remission in that state. But luckily with Crohn's, we can stay on our normal train of thought where we say definitely quit smoking if possible. And then certain medications can flare up Crohn's flare. So things like NSAIDs actually can trigger a flare up, and then certain medications that have like specifically diarrhea as an adverse effect. Obviously, in some cases, we can't ignore them depending on the comorbidity the patient has, but try to limit medications that have GI distress because we don't want to add anything else more to that.
Right.
Psychological things to kind of consider. The mental health changes seem to be associated with remission versus in flares. So things like stress, anxiety, depression. The data seems to be more associated with ulcerative colitis when it comes to psychological changes that cause a flare-up, but Crohn's disease could be a potential as well. And so basically we're getting at multifaceted disease that get lots of different things that can kind of go into the etiology, like Cole was saying. So it's definitely not some sort of a simple diagnosis or simple disease process.
No, it's not extremely clear what the issue might be that's causing it. So they're delineated, ulcerative colitis and Crohn's disease, and a primary easy way to delineate them is the location of where they happen, like Mike had mentioned before, and also kind of what it looks like from if you're literally looking at a perspective. So he mentioned that the UC is generally confined to the rectum and the colon. There's no small intestine transmural involvement. Whereas with Crohn's, it's transmural, also in the small intestine. It can be anywhere from the mouth to the anus. And then UC has the characteristic look, and it's generally described as like crypt abscesses. With Crohn's disease, we often see fistulas, granulomas, and it's more of a cobblestone appearance versus UC, no crypt abscesses. It often involves the terminal ileum and the small intestine, and the clinical presentations can be pretty similar, but chronic diarrhea, it can have some blood, but it's not grossly bloody. Abdominal pain, specifically with tenderness in the right lower quadrant, and it can be, if it's relieved by defecation, that can be a sign as well. Patients can also have fever, weight loss for obvious reasons, and also malabsorption of food and other things.
Yeah, and I think that's, especially when it comes to kind of differentiating that's between the two, they have very specific characteristics that I think make it, if you can kind of keep in mind, like Cole was mentioning, crypt abscesses with ulcerative colitis versus the cobblestone appearance with Crohn's, like some of those key kind of phrases can help kind of differentiate. If you're a student, it's kind of like thinking about it from a test taking or board's perspective, that can kind of help keep it all straight in your head. So having some of those very specific differences is important before you're a true expert. So going through one, I hate to kind of start off with the medication class that we don't really use anymore, but I do think it's important because one of the classes of medications that we've kind of gotten away from is technically FDA approved for Crohn's disease. But some of you may be familiar with like the sulfasalazine, so an aminosalicylate. So sulfasalazine, and then also mesalamine is the newer version
right.
of that. So the sulfasalazine, you're basically counting on the fact that because it breaks apart and one part is absorbed systemically, which is why it can help with certain like rheumatoid conditions and things like that it can promote inflammation in the body. But then the other part is released into the intestinal tract, which is how it helps with Crohn's. So sulfasalazine is still utilized now, just not in Crohn's. You'll see it a lot more in ulcerative colitis. But then the mesalamine, they have all these different formulations of it, and that can get really confusing as well because you'll have things like the Asacol HD, you'll have the Pentasa, you'll have the enemas versus suppositories, and all these in between. Basically, the big difference between this, because they're not all the same, just to give you some background information, the site of action is really the differentiating factor. So just to throw an example out there, like the Pentasa, that's going to kind of be released throughout the entire intestinal tract, which is why that's one we used to think of it being more of a treatment option for Crohn's specifically. And then like Asacol HD also, goes to the ileum, in past the terminal ileum, obviously the proximal colon. Whereas something like mesalamine enemas is going to be mostly concentrated the distal colon, the suppository obviously for the rectum. So those were associated with ulcerative colitis and still sometimes utilized in that disease. The problem is the data in Crohn's disease specifically, even though that we know that we're getting release in the small intestine and where we would typically think of as the site of action, the mesalamine products, regardless of which one you're looking at, don't have very good data, and the guidelines have basically pushed away from the mesalamine products in general for Crohn's. So if you have a patient who has Crohn's disease that's on one of these agents, that's kind of like the old school way of doing things and probably better options available, especially if they're having frequent flare-ups and not maintaining remission.
And even on the previous guideline before the most recent one, it was already kind of controversial and there wasn't great evidence behind it. They kind of took it away with this one, which kind of leaves, and we'll talk about all the different treatment options, but kind of leaves primarily expensive meds. I mean, there's steroids and stuff, but primarily expensive meds. So it's very interesting.
Yeah, it's not great.
No.
From a cost perspective.
No, not yes, from a cost perspective. But if that's what they're recommending, then hopefully there won't be issues getting it covered if the patient's insured.
Yeah, and we'll mention some other options too if they're not insured, because we don't want to leave those patients hanging, obviously.
Right. Just a couple of things about the aminosalicylates, just so you know. Severe skin reactions can happen, so SJS, also hepatic issues, pulmonary fibrosis. They're definitely not the cleanest of meds, but if you're not using them, then it's not a big deal.
Yes, so make sure no more mesalamine if you can help it. We're definitely not gonna. We want the most bang for our buck if we're gonna put patients on these meds.
Right.
So corticosteroids. We'll just kind of mention these briefly before we get into the more elaborate and commonly used meds, but we all are familiar with corticosteroids. Obviously, the thought process is to kind of suppress the inflammation. A lot of times we're thinking about these, if we are going to use them in Crohn's, we're thinking about them along the lines of basically just as a temporary thing to help to sort of get the patient into remission. And then as far as maintenance of remission, we do not want to use steroids. Right. Obviously, we don't want to put them in the long term. So corticosteroids in general can be utilized. To give you an idea, prednisone in doses usually 40 to 60 milligrams per day. The guidelines mention the 60 milligrams per day is the most commonly studied dose, but or an equivalent corticosteroid. If you were to convert it to methylprednisolone or prednisolone or something, but 60 milligrams of prednisone, and then there's also a budesonide as well. Now, there's two different forms of budesonide. So they have, for ulcerative colitis, they have budesonide, what's called MMX technology, and it's basically released specifically in the colon. So the thought process is to avoid the systemic effects of steroid use. Right. So it's a 9 milligram extended release tablet. They use the MMX technology to create that extended release formula, and in ulcerative colitis, it's released where it needs to be in the colon and not in the small intestine. They have another version though for Crohn's specifically, and that one is going to be released a little bit quicker as far as into the small intestinal range, and that is where it's thought to be obviously more effective for Crohn's specifically. However, when you compare it to other corticosteroids, specifically prednisone, it's actually probably going to give you a less robust response, less chance of getting to remission. So what the guidelines basically say is you have to kind of outweigh the options based on the patient's comorbidities and thinking about, okay, if they do have systemic absorption of prednisone, is that going to cause other issues based on the patient's comorbidities? And if the less likely chance of getting to remission with the budesonide, and Entecort EC is the brand name for Crohn's. If that is going to, that risk of not reaching remission with that is going to outweigh the benefit of avoiding those side effects systemically, then that may be an option. But know that you may be getting a little bit of a weaker response with the budesonide, even though I feel like they advertise it as if it's a much better option. The data does not reflect that.
Which I guess wouldn't you, even if you had a well, you might not, but wouldn't putting yourself in the shoes of big pharma
as a business and not someone with integrity.
Yeah, you should use the other company's drug.
You know what? Just use prednisone. Our product stinks.
Ours is expensive and it's not as good.
So that's the big difference in the budesonide. That's the version for Crohn's is 3 milligram extended release capsules, and that one releases specifically the terminal ileum, and so. Technically speaking, they're not really interchangeable either. Sometimes people will swap them out, but realistically, you need one for ulcerative colitis because it gets released further down in the colon. Right. So keep that in mind too. Yeah,
and just a reminder, because everybody knows, but they're not clean drugs, so there's short-term adverse effects and definitely long-term adverse effects if you kept people on these for a long time. So short-term, increased appetite and weight gain. Emotional instability, but I mean, really, people can have aggressive behavior, like the family members will describe that they just don't recognize the behavior that the patient's having sometimes. This can even be on short courses of steroids that people get all the time for various different things. Trouble sleeping, GI upset would be all things that could happen with a short course. Long term, you can have much bigger problems like adrenal suppression, immunosuppression, impaired wound healing, hypertension, hyperglycemia, that can also happen in the short term, osteoporosis, sodium retention, edema, things of that nature.
And, based on that laundry list of adverse effects that steroids can have, that's associated with them, the big question is, like, why are we needing to so quickly kind of maintain the patient's symptoms, besides the discomfort and pain that can be associated with it? Crohn's disease in general has a lot of complications if left untreated and the flares not kind of maintained and pushed to remission. So Cole had mentioned fistulas, which is basically the formation of between the colon and other parts of the intestines, or even like the bladder and things like that. It kind of forms like a bridge, if you will, for lack of a better term. It can cause small bowel obstructions, malabsorption of B12. It can cause nephrolithiasis. It also can increase the risk of malignancy as well, although ulcerative colitis is typically considered to be higher risk of malignancy, or at least leading to the increase in the risk of malignancy. But that's why we're also mentioning the stuff about colon cancer and whatnot, because if someone with Crohn's, we would want to monitor them for that. But ultimately, we wanted to control the patient's symptoms to avoid all those long-term effects. So even if it means we have to use steroids in the short term, ultimately it will hopefully be a net benefit for the patient in the long run. But when we talk about like the actual medications that are a little bit more useful, if you will, as far as not only getting to remission but actually maintaining remission, it's going to be important to kind of think about like the classification or I guess severity, you'd say, of Crohn's disease. And so there's not like a really ideal global classification system. They have some basically classifications that are based on, histological, studies or endoscopic studies. You could have certain scoring systems that are utilized, and once based on a patient kind of questionnaire and symptom score, you can kind of calculate, and if it's a certain score, then that's going to be considered moderate or severe. We're going to be kind of focusing on the moderate to severe patients, so that's kind of we'll be spending most of our time talking about the treatment options for those. So just know though that it may change as far as how we can classify patient severity based on the clinic and all that,
right.
That you're working with.
And the score, so one score that's frequently used is the Crohn's Disease Activity Index, and it takes into account multiple things. It's going to take patients' weight, sex, all that sort of stuff, but specific to Crohn's, they're going to look at the number of soft or liquid stools the patient's had in the last week, their abdominal pain that they've complained about over the last 7 days, general well-being, anti-diarrhea drug use, if they possibly have an abdominal mass, even lab findings like hematocrit, and then some questions related to like autoimmune findings or other complications, like if the patient has arthritis or arthralgias, anal fissures, fistulas, abscesses, other fistulas, if they have a fever. All these are going to add to that point system, and the higher it goes, the more likely it is to be severe or even fulminant disease.
So moderate to severe ulcerative colitis, Crohn's. I'm already off topic. Moderate to severe Crohn's disease. So we've mentioned steroids. That's one option. However, we do have a lot of other recommendations now that we can utilize certain medications to induce remission. We don't have to necessarily use steroids. That may be something that we can kind of start with if we needed to, and then if that's not enough to kind of push them to remission, then we can start pulling out some of the big guns. So I guess, Cole, you want to just kind of we'll go through the meds individually, the classes first, and then we'll kind of lump it all together at the end.
Sure.
And kind of how it all comes together. So to kind of think through we'll start with the older agents. So things like the immunosuppressive, the thiopurines is a big one that is still utilized in ulcerative colitis and Crohn's, but we'll talk about how we can kind of when to use these and how to use them towards the end. But Azathioprine is the very commonly used thiopurine that's still used for various disease states now, but it is a drug that does carry a box warning for chronic immunosuppression, which is what it's for. But because of that, it does carry an increased risk of malignancy in patients with IBD. So that's something to kind of consider. And then as far as some of the toxicities, hematological toxicities are a concern. And there are a patient demographic that has like a genetic deficiency of an enzyme called thiopurine methyltransferase. And so that's basically something that if a patient does have a deficiency in that enzyme, we don't want to be putting them on this because they're not going to be able to utilize it appropriately. And so they actually have genetic testing you can do looking for thiopurine methyltransferase, and that should be kind of considered before initial use of azathioprine or the other version, 6-mercaptopurine, to treat patients, especially in IBD. And if that's available, obviously in certain situations we may not be able to do that, but know that is an ideal situation. We would want to get that genetic testing done to make sure they're not somebody in that population that's going to have to worry about that. Adverse effects, usually GI complaints are a big one, besides obviously the more severe warnings and concerns. But just day-to-day kind of side effects, adverse effects, GI effects rather, rashes can also happen, and then increased LFTs. So you kind of want to keep an eye on the LFTs and make sure they're not going too high up from baseline and just kind of not showing any kind of hepatic toxicity. And then mercaptopurine, similar. Does not carry the box warning though, which is a little different. So to be as safe as possible as far as the immunosuppression and potential increased risk of malignancy, maybe the mercaptopurine may be a better option. However, I feel like a lot of the studies are all surrounding azathioprine. Yeah. So I'm wondering if it's if we studied mercaptopurine more, maybe we'd start to see more of that increased risk. I don't know. That's just me guessing.
Though, as far as the cost goes, azathioprine is going to be pretty affordable.
Yeah,
which is good
for sure.
Yeah, versus the other ones.
Mercaptopurine, you do want to make sure they take it on an empty stomach to increase absorption. That's another kind of just quick clinical pearl.
Yeah, especially because these patients might have absorption issues.
Yes,
at baseline. Next class of agents would be Tnf Alpha Antagonists. So I think we've all probably heard of Tnf Alpha, but it's induces pro-inflammatory cytokines like interleukins. We think of it as an inflammatory mediator. It enhances leukocyte migration, activates neutrophils and eosinophils, induces acute phase reactants, tissue-degrading enzymes, and overall is going to significantly increase the pro-inflammation of these patients who have Crohn's or even UC, of course. So we have developed monoclonal antibody agents that we can specifically target TNF alpha and block it. It's indicated for patients with moderate to severe Crohn's disease. And I have told this story on the podcast before, but I figure I might as well tell it today because we have lots of new Free CE listeners. But I had a professor in pharmacy school who I think was involved in research of TNF alpha, and it was in its nascent stages, I guess as we'll say, the research was. And so he taught this whole section, I guess it was in some sort of pathophysiology class or something, and pretty much all he talked about the whole time was TNF alpha because that's what he did his research on. And so you could pretty much guarantee that on all his test questions, maybe he had 10 of the test questions, that the answer would have something to do with TNF alpha. So if you saw TNF alpha, just circle that answer, then it was going to be right. And it was great. I'm sure I got them all right.
Boom.
But now here we are. We're
talking about it.
It's probably because of him.
Maybe. So some other things to consider with TNF alpha antagonists. Basically, the infection risk is a big warning that we have with those. So anything that's going to be affecting your body's immune response, even including inflammatory response, could put the increased risk of infection. There's a chance that we could cause a worsening of a patient with heart failure. So we want to make sure that they have a history of that. We've kind of considered that as a risk, making sure we have all the necessary monitoring with an echo and all that, or maybe even using a different medication if needed. There's also a potential for increased risk of lymphomas, as well as neutropenia. And so, we got to keep all those kind of more severe side effects in mind. There is also, obviously, because of that infection risk, TB, invasive fungal, other opportunistic type infections can be something that we're concerned with. So we definitely want to get at least initially a negative TB test before kind of starting the therapy, and then periodically after if the patient's going to stay on it long term. And then if the patient does have latent TB, then we want to go ahead and treat that prior to initiating treatment, if possible. Or obviously active TB, but they probably know it,
right?
if they're doing screening, hopefully they've been treated for that.
That would be a problem.
There's specific Tnf alpha inhibitors that are utilized in Crohn's disease. So the big one, Humira, I'm sure we've all seen that one. It's available now as a auto-injector that's a citrate-free medication. Basically, the citrate was thought to be one of the things that caused this injection site reactions and pain at the injection site. So the citrate-free is supposedly, and I've heard patients tell me that it definitely helps with the injection site pain.
Yeah, I've heard significantly.
Yeah. I've definitely I've wondered myself, like, 'cause we have a version of the older version of Humira that's not the citrate free at our clinic in our 340B pricing for like $25 cash price, and I'm like, I wouldn't inject myself with one just to test that, but I want to see how bad it hurts. I really do, just because I'm just kind of curious.
How's your stomach feeling?
Yeah,
got some Crohn's?
Yeah, no, stomach's fine. So it'd be more so for data collection purposes, and I don't think that's what that's designed for. So, Humira is one of them, and you'll see that utilized in ulcerative colitis as well.
Yep.
They also Infliximab, which is an IV infused Tnf Alpha antagonist. So the infusion reactions are somewhat common, and sometimes you'll see patients kind of get pre-medicated with some, Benadryl and things like that beforehand. But it is an IV infusion, so that can potentially add a barrier to care. And then the other version, the brand name Cimzia, I don't feel like we ever see this one utilized in person, and that's actually a good thing, which we can get to the guidelines. I'll explain why. But Certolizumab is Pegol is the generic or actual official name. It's indicated specifically for Crohn's disease. I don't believe they've ever sought FDA approval for ulcerative colitis, but it's also a sub-Q injection. But it's actually considered to be by the new guidelines. Spoiler alert, we'll come back to this, but it's basically inferior based on the data compared to the other Tnf alpha antagonists. So that would be the one that we would kind of save if possible for a situation where we just absolutely had to, whether it was cost or something along those lines.
Right.
Real quick before we move on, because I know Cole had mentioned, the cost of all these and if they have insurance and all that stuff. If you have a patient who doesn't have insurance or self-pay, maybe they're even like a low-income patient, all of these especially now that they have like a lot of the like the biologics that have had, what do you call them? I'm drawing a blank now. Not follow-ons like they call them.
Biosimilars?
Biosimilars. Thank you, Cole. My brain stopped working for a second. But the biosimilars and whatnot, that's one hopefully going to drive or continue to drive the cost down. But these companies that are producing these obviously have certain patient assistance programs, and there are definitely ways to get patients on this. So I don't want you to see an uninsured patient and just automatically count them out. In some situations that may be the case, but there are a whole bunch of different avenues. Send to our clinic if you're in the Charleston area, and we'll take care of it.
I can almost guarantee you that all of these drugs will have a program to where in 2 to 4 weeks, if you submit the appropriate documentation, you can get this patient approved to have the med for free for a year.
Absolutely.
And then just reassess the following year. And usually all they need are some enrollment forms filled out by the doctor, some enrollment forms and HIPAA forms signed by the patient, some income forms filled out, and if they're totally uninsured, that's pretty much it. And then they'll even if they're insured and say the insurance won't cover it or their copay is unaffordable, you can submit additional information like PA denials, appeal denials, letters of financial hardship and that sort of thing, and usually get these things approved. It takes a little bit of extra work, but it could be worth it, especially because if you don't have the staff to do this, the patient can fill out a lot of this stuff on their own, and if they feel like it's urgent enough for them to have the medicine because they're prompted by their disease state, then that could be helpful as well.
Yeah. And there's state, organizations like in South Carolina, we have Vista that has certain expensive medications on formulary that they'll give if the patient's enrolled. We have places like FQHCs, like where I work, where we have a 340B pharmacy where you can get some of these medications really, really cheap. So please don't just write them off and give them nonsense.
A lot
just
of these
because they're
companies
uninsured.
will have a specific rep or a care manager who works alongside the drug sales rep to kind of intermediate with these patient assistance programs too. So ask your reps and get hooked up with them, and they can be helpful as well.
Yes, they want to use these medications.
Yep.
They make a lot of money off the insured patients that are being put on these. So they usually will have plenty of opportunities to get patients covered if they don't have insurance.
Right, and I'm sure there's some hope that the patient ends up with insurance and has it paid for. That's part of it. But I think it's also because I'm sure there's something along the line, tax write-offs and stuff like that. Like they have like Lilly Cares and various different things that it's kind of pitched as like a charity sort of thing. But it's good. It can get patients the drugs when they wouldn't have them otherwise. Very expensive drugs.
Yes. All right. So another drug that you've probably seen at least the commercials for, Entyvio is the brand name. So Vitilizumab, it's another IV formulation. It's approved in both Crohn's and ulcerative colitis. But it's the IV infusion could potentially add a barrier depending on patients' transportation needs and stuff like that. But it is something that can be very useful. It's an integrin receptor antagonist, so it's a completely separate class of medication compared to the Tnf Alpha inhibitors. The one thing to keep in mind is the benefit is usually seen within the first few weeks to at least within the first 3 months, and basically the label indication says if you do not see a benefit by week 14, to go ahead and discontinue that. You probably won't see much benefit after that. Some warnings to consider, the infusion reaction because it's IV is something to consider. The infection risk is still there, as well as the potential for liver injury. So checking LFTs, routine TB screening, just like with the TNF alpha inhibitors, is important. And then making sure that all the vaccines, especially the live vaccines, are up to date, which luckily we don't have to really use live vaccines that much anymore. Right. But making sure that if you have a patient that is up to date on all their vaccines before starting therapy so that you can get the most robust immune response to the vaccine before you put them on something that could potentially suppress their immune system a little bit.
Right.
And then more like common adverse effects. Nasopharyngitis has been increased or reported to be increased risk when you have this medication, as well as the like some joint pain and things like that. And then headaches is often reported as well. But I feel like, especially the headache, I feel like we can get by with that versus the pain of having a Crohn's flare.
Yes, hopefully. So we have another class that has a medication in it, and that's the interleukin blockers. So we talked about that being pro-inflammatory. Anti-IL-12 and 23 antibody is what it is. But Stelara, not an uncommon medication to use. Ustekinumab, another monoclonal antibody. This one is a bit unique because it's sub-Q, but also has an IV formulation. Like I said, blocks IL-12, blocks IL-23, inhibits the receptors for these cytokines on T cells, on natural killer cells, on antigen-presenting cells as well. Similar to the others, increased risk for serious infections, TB. So you need an initial negative TB test and then monitoring after that. Treat the latent TB just like the others. But also invasive fungal infections and other opportunistic infections. So these, since they affect the immune system in this way, definitely can carry those risks.
So there's actually, we mentioned the Entyvio as far as an integrin receptor antagonist, but there's actually another integrin receptor antagonist that's on the market. If you've looked at some of the MS guidelines and treatment options, that you may recognize this drug, but Natalizumab, or Tysabri, the brand name. This is one that's only approved for Crohn's. It's not approved in ulcerative colitis. It's given IV as well. The problem with this is it has a box warning for an increased risk of progressive multifocal leukoencephalopathy, or PML. It's a viral infection in the brain that can lead to severe disability, if not death. So it's a very, very serious, potentially, fatal situation that can occur. And it is there's a REMS program associated with this called Touch, and it's basically to kind of monitor. There's a virus that you'd be checking for, the JC virus that you'd be checking for ahead of time before you start a patient on this. And because of that risk of PML, there's actually been a lot of post-marketing surveillance that's been done, and this is one that we have used in Crohn's disease in the past, but the newest guidelines actually recommend against its use. And so that's kind of a big change because, obviously it's a whole medication class. This is approved for Crohn's disease specifically, as well as MS. But they basically have said the risk of PML is to a high extent that they really would recommend not using this medication. They say if the patient is kind of tried other options and we're kind of stuck, explaining them to them the risk of the PML development, and if basically the potential for remission outweighs that risk and they're okay with that, then you could consider it. But the guidelines basically suggest against its use.
Yep.
It also causes the infusion reactions because it's an IV formulation, the headache, fatigue. It can induce depression, and then patients have often reported like abdominal and back pain as well. So not the cleanest medication that we have available, but Natalizumab, it's off the good list now, at least for Crohn's. But we'll come back to that when we clean all this up and put it into context.
So thinking a little bit about what you're going to do if you have a mild patient with Crohn's disease, or if you have a moderate to severe patient with Crohn's disease. So in a mild patient, like we kind of said before, we're thinking corticosteroids. So there is a controlled ileal release budesonide, like we talked about, 9 milligrams once a day, can be effective. Should be used for induction of symptomatic remission, and you can continue it up to 4 months to maintain remission. So like we said, the mesalamine and the sulfasalazine probably shouldn't be used in this situation. And also antibiotics, which Mike talked about, the fistulas, wouldn't be effective in this instance either, just to kind of induce remission in a mild case.
Yeah, they used to use metronidazole and Cipro. It's kind of like the antibiotics that would be utilized in Crohn's, and that's also been discussed as not kind of being taken off the table now as well. So some of our old school stuff, definitely not recommended anymore.
Yeah, it's very interesting. Well, it means we're getting better drugs, right?
Yeah, for sure. All right, so let's break it down. So we have moderate to severe Crohn's disease. Based on the guidelines, we have the Tnf Alpha Inhibitors is kind of usually what we think of as like a good first line option, especially if we're not going to use steroids. Tnf Alpha Inhibitors, they basically recommend, the guidelines recommend, this is from the American College of Gastroenterology, but the American Gastroenterology Academy, Sorry.
That's just kind of a silly one, though. Do they ever have American, then the name, then Academy at the end?
No. I don't think
nobody
so.
else does, right?
I don't know. We should probably double check that before we say
I'm going to say that there's no one else that I'm very positive
in the
about.
History. Okay, right on. Cole's positive.
It should be AAG.
Yeah, I like that better.
So, yeah.
That's true. That make more sense. All right, so you have a patient with moderate to severe. They do recommend a Tnf Alpha antagonist over no treatment when it comes to induction and maintenance of remission as well. And so the data as far as kind of which of those agents to pick, because before we used to say any of the Tnf Alpha inhibitors that are approved, go for it. Now there's evidence that kind of support the use of Infliximab as well as Adalimumab, Humira, over the Citralizumab. That one has kind of low evidence associated with it and how effective it is versus the moderate efficacy and evidence that's seen with the Infliximab and Adalimumab. So between those three Tnf Alpha inhibitors that are available, the Infliximab and Adalimumab would be the way to go if possible. The Citralizumab, not nearly as effective based on the data that we have. They also say that you could use the Entyvio, the Vitilizumab, as well. It's going to be suggested to use that over no treatment for induction as well as maintenance therapy. And then the Stelara that Cole had mentioned also is another one that they recommend for induction or maintenance of remission as well. This is the part that's one of the first parts of the recommendations is when they bring up the Natalizumab, and they say that even compared to no treatment for induction and maintenance of remission, they suggest against Natalizumab over no treatment. So it's basically saying that they would almost rather you not treat them than give Natalizumab. That's saying something. I think it's a moderate level of evidence recommendation. So basically, they base it off of, like I said, the post-marketing surveillance data showing that PML risk is probably not worth the the benefit you'll see. So not enough bang for your buck, if you will. If you are going to use it, like I said, that JC virus or the John Cunningham virus, they want to make sure that you have you do the antibody test for that and then get a negative result, and then monitor it over time,
right,
and make sure if you are going to use this med, but they recommend against it.
Yeah, and so I mean, similarly, that's kind of the same stance they take about the thiopurines, because they recommend against the use of those over no treatment for achieving remission. They do actually make a caveat that the use of thiopurines over no treatment for maintenance can be done, or patients in corticosteroid-induced remission, it could be done. But yeah, in general, they also give that level of evidence to be very low. So, yeah.
And then the question becomes, okay, well, is there any benefit between giving a Tnf Alpha inhibitor along with like immunosuppressive therapy? And there is actually some data that's been shown that maybe that combo is appropriate. So kind of the thing to think about is the Sonic trial. I don't know if you guys have seen this or not. It's kind of, I can't remember the exact date in the year that this came out, but it's been out for a while. But basically what they looked at is infliximab plus azathioprine versus infliximab or azathioprine as monotherapy. And they saw that the combo was statistically significant. The combo is better than either agent used by themselves. And just to give you an example, when they could look into the primary outcome, the corticosteroid-free clinical remission at week 26 was kind of like their primary outcome. They saw that the combo was superior to infliximab with a number needed to treat of 8, and then the combo was superior to azathioprine monotherapy with a number needed to treat of 4. So the combo therapy, and again, that's to basically induce remission, not necessarily for maintenance. So the combo could be utilized there. And then the guidelines do point out that the combo with methotrexate is also a potential, but they are very specific about the formulation of methotrexate,
right? Being
sub-Q or IV or IM formulations, not the oral formulation. Cole and I were chatting about this beforehand, and our theory based on without looking at
theory. I think it's proven.
Is it proven? I haven't double checked, but I feel like it's good enough. We'll say theory just in case we're way off, but I think it probably has to do with the absorption of taking it orally, specifically in Crohn's is where we don't really want to. We want to stay away from the oral methotrexate and give sub-Q or IM versions weekly instead.
Right.
But even though the data is kind of around the infliximab azathioprine combo, it doesn't mean that you won't see Humira and azathioprine utilized together, or with methotrexate or something like that. They can be kind of extrapolated in some cases. Obviously, the level of evidence is going to be not as nearly as high, but that could be a potential option. But if it comes down to the patient will only take one therapy for the induction of remission, we remember the Tnf Alpha inhibitors or one of the other biologics is absolutely going to be the go-to. Right. The immunosuppressive therapy is monotherapy is not going to be utilized for induction, like Cole was saying earlier. So that's something important to keep in mind. So then it can also be obviously a barrier for someone who doesn't have insurance, like we had also mentioned. So I feel like it's very easy to just default back and just give me azathioprine. It's cheap. Try to do your best to get them on one of these.
It's worth a shot.
More expensive meds.
It's worth a shot.
And then, like we were saying, as far as if you've used one Tnf Alpha inhibitor, there is some evidence, especially with Humira being the first line. If Humira was the first line drug used, you don't necessarily have to switch to a separate class if you don't have. You don't see benefits with adalimumab. There is some evidence that you could potentially use infliximab, even though they're in the same class, as a second line agent. And you see this with like rheumatoid arthritis and stuff as well. They'll say, if one TNF alpha inhibitor doesn't work, doesn't mean that the other ones won't. That's going to be kind of, again, a decision between you and the patient. And it may be something where, sure, you could use infliximab, but they can also get Entyvio or Stelara covered. So then why not switch to something like that?
Right.
But just know that if that's, for whatever reason, that's like the option you're kind of stuck with, you can try another TNF alpha inhibitor, especially if infliximab is always kind of thought to be a little bit stronger, I guess you could say. So definitely something to consider there. So we mentioned not using thiopurines as monotherapy. However, once a patient is kind of induced into remission, so they've gone through the induction process, you're in remission. In that case, you could potentially use thiopurines to maintain that instead, and that's what they recommend over no treatment at all.
Right.
The other option would be to use the biologic as monotherapy.
So that might be an instance if they couldn't continue on the biologic for whatever reason, they're saying use the thiopurine instead of nothing.
Yep. And then the one difference to the immunosuppressive agent is if you have to use immunosuppressive therapy for induction and you don't have, let's say, just absolutely there's no way to get a biologic, in that case, methotrexate monotherapy, IM or sub-Q over no treatment. Whereas that's not really a recommendation with the thiopurines and all that. So ideally we want biologics, but worst case scenario, methotrexate is still an option as well as steroids too.
Right. So there's options.
Yeah.
So what updates did we miss from the guideline?
So what I just was talking about was directly from the new guidelines.
I think we hit it all right.
And basically keep in mind, obviously, the escalation. If the TNF alpha inhibitor is not there, then using the Entyvio as an option or Stelara as well. There's some evidence that shows that adding the purines as well as or methotrexate could potentially help with the Entyvio and the Stelara as well. But it's one of those things that you could recommend that they say specifically that they don't make a specific recommendation regarding that because the data is kind of lacking. They just have it listed as a knowledge gap. There are definitely clinicians out there though that will use the combo, but that's kind of extrapolating the TNF alpha inhibitor data along with the thiopurines. The data that's seen in that class combo. We can't directly say. We don't have any data to support necessarily the use of Stelara or Entyvio in combination with methotrexate or thiopurines, but I will say I've seen it before utilized, but it's considered a knowledge gap as of right now. So they do actually specifically mention that.
Right.
And then the other question, is kind of okay. Well, how long can they be on a biologic? That's the other thing that they're not super clear about based on, again, kind of being a knowledge gap. Once the patient has kind of reached remission, then we always think at least consider de-escalating therapy. So maybe instead of the combo, we can go to biologic or the thiopurine by itself or methotrexate by itself. But that's really, I would say, be a conversation between you and the patient to kind of figure out where you need to go. And since there's not a lot of great data as far as the true long-term effects of a biologic with the increased risk of infection and all that good stuff, definitely something that you may want to use a little bit of caution with. So, recap real quick for those of you who, if you're following along at home, hopefully, we're going to induce remission with either steroids and maybe in more mild cases, or if we haven't had too many flare-ups to begin with. But the other option, obviously, being the biologics. Ideally, we would want to use a biologic plus an immunosuppressive agent. But if you have to choose between the two, definitely biologics hands down is going to be the option. If that's not enough to reach remission, we could consider another TNF alpha inhibitor, especially if Humira was utilized first. And then from there, we can go to the Entyvio with or without immunosuppressive therapy. If that's not enough, then we can graduate up to the Stelara as well. It's also, technically speaking, you don't have to go in that particular order, but that's kind of how I think about it, especially from a cost perspective. And getting things covered, they probably are going to want to see that you've used some of the other agents first, especially the ones like the TNF Alpha Inhibitors have been around a lot longer, so they're going to be on more formularies and all that good stuff. And then once you have remission, consider de-escalating therapy and monitoring kind of from there, hopefully keep them in remission, but just weigh the pros and the cons of which therapy you're going to DC and which one you're going to continue.
Right.
and then hopefully keep the patient in remission for a long, long time.
And fix it.
Fix it. Well, kind of. Suppress it.
Suppress it.
Yeah.
So I've got some stuff on cancer.
Talk to me.
If that's all you got for Crohn's.
That's all I got.
Okay. So Crohn's does put you at an increased risk for colon cancer. So we decided we wanted to briefly mention a couple things about the recommendations, especially because in the last few years they've adjusted a little bit around the age of when they recommend cancer screening. So we're transitioning a little bit to colorectal cancer. So primarily, where we go for these, there's a couple different guidelines and recommendations, but the U.S. Preventive Task Force is a pretty good place to start. So in general, when you think about a colonoscopy, you're usually thinking of age 50, right? So they have decreased that recommended age to 45 now. They don't have as strong a level of evidence with the ages 45 to 49 population with the screening, but they have adjusted the recommendations to say 45 and up, we think that they should be screened in some way. And then they have a higher level of evidence with ages 50 to 75 to say that we definitely want them to be screened. And then 76 to 85, it kind of goes lower because it's a risk-benefit kind of thing. You know, what are you willing to do about what you find kind of thing. So age 45, that's kind of the big change. So I wanted to mention a couple of the tests too, because we all think of colonoscopies and we all probably also think of stool tests. So there's a couple of different with stool tests for one, but also related to colonoscopies. They classify that as a direct visualization test, and there's a couple of those as well. I think the stool tests are pretty interesting because I'm more interested, I don't have all the information here today, but I'm more interested in knowing, like, are these reliable? Is this something that we can use in place of, or blah, blah, blah. So they give a little bit of information on the U.S. Preventive Task Force about these tests. So thinking about the stool-based tests, there's 3 different ones. There's a high-sensitivity guaiac fecal, I don't know if that's how you say that, guaiac fecal occult blood test, GFOBT. That's one. There's also a fecal immunochemical test, so they call that FIT, F-I-T, and also a stool DNA test, all 3 of those. I won't get into all the details, but effectively they kind of think of the FIT test and the DNA test as being a little bit better than the guaiac fecal occult blood test. The FIT test and the FOBT test are both looking at blood markers. And so the FOBT test, they use different methods for this. The FOBT looks at chemical detection of blood, while the FIT test uses antibodies to detect blood. The DNA test is different. It's exactly what it sounds like. It's looking for DNA biomarkers of cancer that has shed from the lining of the colon. And there's only one FDA-approved DNA test, and it's actually a combination of the DNA test and the FIT test. So it's going to have the DNA monitoring plus the blood monitoring. And it's called the sDNA FIT test. So all of these would be examples of stool tests that you can get. Now, it's different, right? So I'll talk in a second about the colonoscopies and the time ranges and that sort of thing. With the stool tests, in general, they recommend having that done every year. And basically, if it comes back positive, i.e. comes back concerning, you're going to have a follow-up colonoscopy anyway. But they've determined that having either the FIT or the sDNA FIT every year is going to provide greater life years gained than having the FOBT test every year or having the sDNA FIT test every 3 years. Basically saying a yearly test for the fecal blood test would be, or the fecal stool test would be better. And then if there's anything concerning, it needs to be followed up with a colonoscopy.
And I think that's the other thing about that too, is because when they mention this is, kind of why they have like levels of evidence and things like that is because there are potential risks, obviously, with a colonoscopy, or if you're doing like a CT scan as well. There's a couple different ways to get, imaging and more elaborate, more robust tests done, but they all have a potential, adverse outcomes associated with them.
Right.
And so the concern is, if we do one of these FIT tests, especially the earlier, screening earlier patients, could we run the risk of, sort of a false positive, which I've seen those myself at our clinic with the FIT test coming back positive, and then they get a colonoscopy, nothing's wrong. But I've also heard case reports and patient testimonials where they got screened earlier based on the new U.S. Preventive Services Task Force recommendations, and they ended up finding lesions based on the colonoscopy and then having those removed. And
something that would have caused a problem before they were 50.
Yes, and I actually know someone personally who's passed away in early age, of colorectal cancer, and it's something that definitely can. It can show up when sometimes it's too late, and so it's something that I like I definitely like the recommendations that they moved it earlier. If you hear some concern about it, though, that's the potential concern is that we're testing these people with more invasive tests that could cause negative outcomes. But I know me personally, if I was a patient in that situation, if I was 45, I would definitely choose to go ahead and start the screen process, because to me that's the risk of catching something or the benefit of catching something early is far outweighs the risk of something potentially going wrong.
And I agree. Personally, for me, I would say the same thing. And that's why as a clinician, you have to take guidelines as guidelines, right? And you're going to make this decision between you and your patient and what their concerns are and what you know about safety and efficacy, right? So the U.S. Preventive Task Force has to make these decisions based on population health. And they're going to look at things like, okay, so maybe we caught this many cancers, but we also had this many bad outcomes. And so that's why, they have certain levels of evidence, or they might not recommend a certain age versus another age. But, just because the patient is 44 years old and 350 days doesn't mean they can't get a screening test or something if they have concerns or family history or whatnot. But did want to touch on a couple of the visual tests that you mentioned. So there's obviously the colonoscopy. Mike mentioned the CT scan, which is called a CT colonography. And then they also have a flexible sigmoidoscopy. The flexible sigmoidoscopy doesn't view as much as the other two. And then the CT scan views kind of more than the others do because it can see some extra colonic areas. So the reason that could be concerning is because it might reveal something concerning, maybe that requires additional workup, and then it turned out to be nothing, and then it was unnecessary. Could reveal something that was concerning that required additional workup that happened to be something concerning and needed workup. So it's one of those things. That's why people don't get full body CTs all the time, because they're going to find things that they need to look into that might not be a big deal.
There's also that risk of there's some data showing that maybe the more CTs you've had in your life, that could actually increase the risk of cancer by itself. Mm-hmm. So that's the other thing to consider is all this. We don't want to be just screening people for the heck of it with a CT scan, because that also could increase the risk of some kind of malignancy. Right.
And so generally the colonoscopy or the CT colonography are preferred over the flexible sigmoidoscopy, but I think most people just do colonoscopy. Yeah. The colonoscopy is also only recommended every 10 years. CT colonography and the sigmoidoscopy are every 5. Personally, I'd rather have it every 10.
Yes. And you get a little propofol nap.
Yeah.
You sleep great. It's no big deal.
Lots of gas. They blow you up,
It's the prep beforehand
man.
That you don't want to have to deal with.
Though neither of us have ever had to do it. We just have heard a million people talk to us about it because we've dispensed it 100,000 times.
And I've even had family members that got tested early and things like that, and I've seen the the not so fun aspects of having to drink all that liquid.
Yeah, see, I have a family history of colorectal cancer. Yeah, and so my mom basically wants me to be screened at when I turn 30. She's like, "You need to be screened." I'm like, "Mom, listen, I'll talk to the doctor. We'll see what he says."
Mom, are you a licensed physician? That's good. I love that. Yeah. Lucky for you have plenty of people to ask in your family, right?
Yeah, plenty of people give me recommendations.
a lot of medical professionals in the Swanson household, and family tree.
Yeah.
What'd you think? We miss anything?
No, that was great. I look at that.
I like how we was in the middle of the podcast. Yeah, it was great.
Yeah, I think we nailed it
based on our own evaluation.
I think we crushed it.
Yeah. And it's gonna prompt somebody to be like, go on the evaluation after they take the test to get their credit and be like.
So what we should do at the end is just be like, "Oh, Mike, that was the worst. That was so terrible. Sorry," just apologize a bunch of times, and then out of sympathy, they will go on and give us really good reviews.
5.
No, you guys actually did really good. We really liked it, even if it's mediocre.
That's a good strategy. Because right now what we've got is a solid 4 going on because people are like, "It was all right," but come on.
We don't have a solid 4. It's 4.9.
No. I mean, when they do the evaluation after the test.
They're
going to be like, they were a little bit too
I see.
self-indulgent. So, 4.
I got you.
Give us a 5. All right. So thank you guys so much for listening. I hope that was helpful. If you have any questions or comments, concerns, anything, obviously our emails will be in the show notes. Make sure that you go to the link in the show notes, like I said at the beginning, if you are a member of freece.com and claim your continuing education credit for this, for you that are licensed and needing such things. Thank you to freece.com and letting us continue to work with them. It's been awesome. They are fantastic to work with, and so I definitely appreciate them and their support. And if you guys have any other questions or anything like that, you can always reach us on the social media platforms as well. You can text the number in the show notes to get in touch with us via text directly. But we'd love to hear comments or suggestions for future episodes, things like that. Make sure you check out Patreon. It's patreon.com/coreconsultrx. We have all of our more lecture style videos on there that have the PowerPoint slides you can download as well. And so I'm in the process of uploading more videos now, especially now that I'm back teaching at the PA school. That's in full swing. And so I'm going to be having a lot more lectures and updated slides and all that good stuff. So as they learn, you're going to learn. And definitely support this. Appreciate the support that we've gotten on that platform. That helps us a lot when it comes to finding better equipment and all that good stuff. So very much appreciate you guys there and for sticking with us all this time. We will catch you guys on the next time. Have a great one.